Hey everyone, Dr. Shaikh here from The Dentalist. Today I decided I should record my video in the open. Welcome to Chapter 20, which is Requirements of Direct Filling Materials and Historical Perspectives. Before we begin, if you're preparing for dental materials exam and want structured help, I would love to coach you personally in my one-on-one coaching program. Just use the link below in the description, and you can also book a free call if you have any questions, and make sure you join the Dentalist Gold email list for notes, updates, and practice materials. I've also crafted a 10-day crash kit very carefully for you guys. So if you want to check that out, that's also linked in the description. Make sure you check it out. It's very helpful for a lot of students. I'm getting really nice feedback regarding that. So make sure you check that out. It's called Crash Kit for dental materials. All right, now back to the topic. So, what are direct filling materials? Direct filling materials are materials that can be placed directly into a prepared tooth cavity and set inside the mouth. They are used for restorations primarily in conservative and operative dentistry. These materials must satisfy specific physical, mechanical, chemical, and biological requirements to be successful in the oral environment. Ideal requirements for direct filling materials, according to McCabe, would be biocompatibility, which means that it must not irritate pulp or surrounding tissues. It should be non toxic, non carcinogenic, and non allergenic. It should also have good adhesion to the tooth structure. Ideally, it should adhere to enamel and dentin. It should reduce micro leakage and improve retention. Then there's dimensional stability. It should not expand or shrink significantly on setting or with time. It should prevent marginal gaps and secondary caries as well. The next point would be ease of manipulation. So the restorative material should be easy to mix, insert, sculpt, and finish. It should have suitable working time and good consistency. Radio opacity is also another factor. It should be visible on radiographs to detect restoration margins or defects. Aesthetics is also an important point, especially for anterior teeth. Color, translucency, and polishability matter a lot. Next point is strength and wear resistance. The material must withstand occlusal forces without fracture. It should resist abrasion from chewing as well. Thermal properties also matter a lot, so the coefficient of thermal expansion should match the natural tooth. Low thermal conductivity should be there to protect pulp. Then there's setting time and polymerization. The material should set within a clinically acceptable time. There should be minimal polymerization shrinkage as well, especially for resin-based materials. Then there's shelf life and cost. It should be stable in storage. It should be affordable and easily available. Now, let's talk about some historical perspectives of filling materials. Let's take a quick tour through history to understand how restorative materials have evolved. Let's talk about gold foil restorations first, which is also called as direct gold. One of the earliest restorative materials used in pure metallic form, condensed into cavity, is gold. It has excellent biocompatibility and longevity, and it is technique sensitive, uh, expensive, and time consuming. Then there's amalgam. It was introduced in the 19th century. It is an alloy of mercury with silver, tin, copper, etc. It is durable, easy to use, and has self sealing properties. There are concerns over mercury toxicity and poor aesthetics as well. Then there's silicate cements. It started getting used in early 20th century for anterior teeth only. And then it is aesthetic but weak and is soluble in saliva. It does release fluoride. Then there's composite resins. They started emerging in 1960s as tooth-colored aesthetic adhesive restorations. Initial versions had high shrinkage. Newer versions are now improving the polymerization shrinkage factor. Then there's glass ionomer cements. They were introduced in 1970s. They bond chemically to tooth, release fluoride, are less wear resistant but useful in non stress bearing areas. Now, the modern developments that you should know about include bulk fill composites, then there's bioactive restorative materials, resin modified glass ionomer cements, nanocomposites, and universal adhesives. These innovations aim to combine strength, aesthetics, ease of use, and biocompatibility into one ideal material. Let's talk about common exam questions now. So, what are the key ideal properties of direct filling materials? It's biocompatibility, adhesion, strength, aesthetics, dimensional stability, and ease of use. Why was gold foil considered the best material historically? Because of its longevity, biocompatibility, and resistance to corrosion. What is the main drawback of early silicate cements? The high solubility and poor mechanical strength. Which material bonds chemically to the tooth and releases fluoride? It's glass ionomer cements. Now, to summarize, the direct filling materials must meet strict biological and mechanical requirements. The ideal properties include strength, adhesion, aesthetics, and biocompatibility. Historically, gold, amalgam, silicates, composites, and GICs have evolved. Modern trends are actually aiming for an all in one material with bioactivity and aesthetics, which we're still striving for. So, if you're serious about mastering dental materials, I'd love to guide you through my one on one coaching program. The link is in the description. You can also book a free call to clarify anything that you might want to ask. And don't forget to join the Dentalist Gold email list for bonus notes and updates. I will remind you again to visit the Crash Kit because it's helping a lot of students throughout the world. The link is in the description. If this video helped you in any way, please like it, subscribe, and turn on the notifications for more chapters coming up. All relevant links are in the description below. I will see you in the next one. Take care till we meet again.